Now, Catherine Biga. I'm proud to present Dr. Biga. She is the Vice President or President-elect of the American College of Cardiology, and it has been our tradition to have the incoming President of the American College of Cardiology for this meeting for the last 10 years, and we are honored to have her here for a very relevant topic today, the top 10 environmental challenges for cardiologists. So, Catherine.
You are so kind. Good morning. And it's actually my honor to be here. I'm humbled to be in front of such an august crowd, and a huge amount of thanks to Dr. Sharma, Dr. Arula, and Dr. Kanini. Dr. Fuster, you amaze me every time I hear you speak. I keep thinking we've got this figured out, and then I realize we really don't yet. And that's much like what I'm going to talk to you about today is my role. My day job is in Chicago. I have 14 acute care hospitals, about 110 cardiologists and APPs. And what I'm trying to do is make sure our world stays alive and health economics so that you can continue to do the work that you do, that our cardiologists across the country really need so that we can take care of this burden of heart disease across the country. So what I thought I would do, since we're in the top 10, I thought I'd start with 7 and I'm going to end with 11. So somewhere in between there is my top 10 components. This is actually a slide that I have been using for quite some time because it really identifies quickly where we're at as it relates to our healthcare system in the United States. As I travel internationally, it amazes me that we're not so different across the globe. Cardiovascular disease is a huge burden, and we haven't figured out how to pay for it. So the compression of margins and the contraction of inpatient volume continues to impact how we deliver cardiovascular care. And what we're going to do in 30 minutes, because I do tend to talk fast, so I'll try to slow down, but it's probably highly unlikely, is to really sort of tell us how COVID changed how we deliver cardiovascular care. We have got to do it differently, because as all the new science and technology evolves, all the AI evolves, we still have a huge number of patients who do not have equitable access to cardiovascular care. So doing things the same way we've been doing them is just not going to work. So I'll let you look at this. This is what came out of some of the trade journals. And then I did my own Kathy Biga top 10. So my own Kathy Biga top 10 is what we're going to go through today. We're going to talk about the rapidity of changes, specifically how it impacts our physicians. And then I also happen to teach a course with a little school called Wharton. And we just went through what they didn't get to top 10, they got to the top 12. So now as we sort of look at these 3 different lists that I've just shown you, you will see that the similarities between all 3 of them are incredibly significant. They talk about the delivery of value-based care, they talk about team-based care, they talk about patient outcomes, they talk about AI, and yet how do we do this at Mount Sinai as well as across the country? So let's start with number 10, and that's value-based care. Some people think that value-based care is sitting out there somewhere, that it doesn't exist. I'm here to say it exists in spades, and that we're all functioning under a value-based care model. In 2022, our Medicare population was 65 million. You can see 2032, those baby boomers, I'd like to thank you all for working so that us baby boomers can be taken care of. 82 million baby boomers. Medicare Advantage. Physicians tend not to really want to listen to Medicare Advantage. They just think Medicare. But what I see in my administrative role is that our traditional Medicare exponentially drops every single year as more and more patients go into Medicare Advantage plans. Why is that? It's because they get their drugs covered. It's because they get vision covered. It's because they get health systems covered. So that transition for beneficiaries is happening at a rapid pace. Now, why do we care as physicians and healthcare administrators? Because it then starts to follow the same rules as our private payers. So all that pre-authorization, all those administrative burdens that we have to deal with every day continue as that population continues to increase. Also, only 1% of the patient population is responsible for 21% of the spending. The other thing that you'll hear a lot about is that we spend 80% of our healthcare dollars in the last 18 months of life. What does that tell you about our society? It tells you that we tend to not want to talk about death. I think we all think we're going to live forever. We don't want to talk about palliative care. We don't want to talk about hospice. So as we talk about our teams, we need to have our palliative care and our hospice individuals with us so that we can help families transition, because we cannot support the expenditure of that many dollars in the last parts of our lives. The reality is we don't all live forever, sometimes thankfully. The other thing that's really critical is looking at physician compensation. So let me just say, although people will argue with me, physicians are not the responsible party for the healthcare dollar spend. We are the lowest in the graph. If you listen to the Wall Street Journal the last couple of days, you saw United posted their profits. They were not insignificant. So we have our health insurance, we have, our systems are very problematic right now. Their compressions are very, very low. But the bottom line is it's not the physicians. Anybody that sits in the CAC meetings or the MedPAC meetings that determine how we get paid know that physician pay continues to not keep up with inflation. And the cost of cardiovascular care is extraordinary, especially in the United States, and yet our outcomes do not match our spend. So spending $320 billion, and we don't have any ceiling on this anytime soon, continues to increase that heart mortality from cardiovascular disease. It is still the leading cause of death. And actually in the United States, we are not changing the trend. We are going up, we are not going down. So we need Dr. Fuster, we need all of you to help us figure out all the ways of identifying this disease, and then we need to get that to the patients at the bedside, to our clinicians. So what is the government doing? Well, this just came out August 1st of 2023, and it's a pretty hefty mandate. It came out from what's called CMMI, which is the Innovation Center of Medicare. I won't bore you with the details of how they actually operate, but what they have basically told us is that by 2025, we will be driving accountable care across Medicare. So I know all of you have forgotten about MIPS, all of you have forgotten about some of the things that have been out there from the government, but I'm here to tell you that we will be seeing some type of bundled care payment for bundles in the not too distant future, because all Medicare beneficiaries will be in a risk-based contract by 2030. That's not that far away. 7 years will go very, very quickly. So our fee-for-service world that we worry about, all those RVUs that people look at, we're here to say that Medicare can't sustain that. And how are they going to move all these beneficiaries in 7 short years? So that's our value-based care. It takes leaders to take us through the next 9. There's a lot we can impact nationwide, but the next 9, we need to understand that if we don't make a decision, we're making a decision. We need to understand that we are leading this. We cannot look to our right or to our left, but we must create that culture that embraces those changes. And we have to be comfortable with uncertainty, because with uncertainty will come agility, and with agility will change how we actually deliver this. So you're it. Help me out here. Team-based care. I'm a huge proponent of team-based care. I like to think it's one of the reasons why I'm helping to lead the college through this next strategic plan of ours. The transition of MIPS, which again, I'm not going to go into because I don't want your eyes to glaze over, but these MVPs, these pathways are here. You could actually report on them next year because they'll be replacing MIPS in 2026, and cardiovascular is one of them. So if you ever want to learn more about it, it's one of my favorite topics, but just suffice it to say that as we move to team-based care, it's going to be driven by Medicare. What is team-based care? Team-based care is that delivery of care across the full continuum. It's taken us out of our silos. So I'm very fortunate in Chicago that we have got a service line methodology. So we start with our patients at home, office, hospital, home, SNFs, ECFs. Our APPs go throughout the continuum with our care. So we are into a consolidated methodology with our physicians as leading. It also involves scheduling procedures for the patients, patient pathways. How can your patients get through Mount Sinai? I didn't try to walk through Mount Sinai, but my guess it's a pretty big organization, and getting patients from point A to point B require an awful lot. It's also going to be the development of subspecialty clinics. These are how, when I first went into cardiology back in the 90s as my top, key professional growth, we didn't have this. We had cardiologists. Think of the subspecialization that we have now. We don't just have interventional and EP. We have people skilled in CTOs and in all kinds, structural heart, mitral clip, all of the things that you have designed and developed and put out in guidelines that are very important. These are how I believe we're going to be delivering cardiovascular disease, using our APPs to help run these clinics with physician leadership. It's how we will transform clinic. You have to have a physician champion in order to do that. You have to figure out how to get patients in. The access component, the stranglehold we have for patients right now is significant. If I were to call our colleagues at Mount Sinai, how long would it take me to get an appointment? How long would it take me to be able to get seen? How easy are we making it for our patients? How easy are we making it for our patients that can't get to the hospital? Where are our clinics at? And then I'm a believer in disease management, especially our chronicity of diseases within the cardiovascular spectrum. We need to treat our AFib patients, our heart failure patients, our cardiometabolic patients personalized. We need to have plans that will work for them. So another part of team-based care. Number 4, compressed hospital margins. In case you haven't heard, hospitals are having a devil of a time. It is very, very difficult for hospitals to function right now. Many of them are functioning in negative margins, meaning they have no money. Their expenses have outweighed their revenues. A lot of that is coming from the dramatic increase of staffing costs since COVID, increase of supply cost. My guess is you're feeling it here in New York. There are some days we have to close our cath lab because we don't have enough staff. So staffing and margins tend to be really, really difficult. And these margins aren't going to get better. When I ran a hospital, we had a margin of 20%. This year, we're going to be lucky if we get 1%. So very hard, no margin, no mission. Keep that in mind. So it's going to be very, very difficult to do. What are some of those things that are going to hurt margins? Well, I'm going to talk for just a few seconds. I don't want your eyes to glaze over, but I'm a strong believer that site neutrality is going to happen pretty quickly. So I'm going to give you a 30-second primer on how you all get paid. Because as awesome as you all are, I assume you all want a paycheck at the end of the day. So that's sort of my role as administrators, to make sure that we get paychecks to people, because that's how the United States works. These are the 3 ways we get paid. We get paid from the physician fee schedule, we get paid from inpatient or DRGs, and we get paid from outpatient or APCs. And we get paid because of CPT codes. That's just sort of the basic premise of everything. In cardiology, we have 4 places we deliver care to our patients for the most part. We have the inpatient hospital, we all know that well. We have on-campus hospital outpatient department, your non-invasive imaging, patients come in for an echo, they go home. We have off-campus hospital outpatient department. That's where, when physicians became employed between 2010 and 2011, 80% of all cardiologists across the United States are now employed. Most of their imaging is done off campus. It's paid differently. And then we have our office setting, which is where you see your patients in the office, and that's how we get paid. What happens with site neutrality is they want to level that playing field. I like to use echoes and treadmills as an example. An echo gets paid $168 on the technical fee in a physician office. It gets paid $453 in a hospital outpatient department. Pretty big delta. A treadmill test has an even larger delta. Nuclear has a large delta. So imagine if the insurers stop paying the hospitals the $800 or $900 for nuclear and roll it back to the physician price schedule of $400, what that will do to our bottom line. So important to understand how that works. And there's a lot of chatter in Washington about site neutrality, which will say we will pay at the lowest level for any of our stuff. And then we have ASCs, ambulatory surgery centers. As more and more procedures exit the hospital and go into ASCs, that's on another different payment model. So I thought I would just put up here for you just a little bit. Now again, rates change wherever you are in the country. It's called a geographical distance. So this is just an example of what different things that we use in cardiology, how they change between the physician fee schedule in green and the hospital outpatient fee schedule. And of course, your DRG, if you happen to do a cardiac MRI while the patient's an inpatient, it will just fall in their DRG, and your administrators won't be happy because it's just a cost of that DRG. So that's how that works. I do believe that all organizations should be developing an ambulatory-based procedure care strategy. We have proven since COVID, patients don't like coming into the hospital. We can provide safe care out in our ASCs. Of course, everybody's waiting to see what happens with EP. Right now, ablations are not allowed to be done out in ASCs, but many of our diagnostic CATs and our PCIs can be done, plus a lot of our peripheral vascular procedures are done out in our ASC. So developing an ambulatory strategy falls into one of those top 10. And I won't read you all this, the off-campus provider component. It's just a new rule that says that you can't just go plop an imaging center away from the hospital, that in order to receive that higher reimbursement, it has to be on campus. That's what all that says. Physician alignment. I do want to spend just a couple seconds on what's happening with physicians. We all know that there's a shortage of physicians out there. Sometimes we don't treat it like that, but we're also seeing some dramatic changes. I work with a group called MedAxiom. MedAxiom is the business side of cardiology. They're aligned with the American College of Cardiology. This is where the data comes from. They just released their survey. They're the first ones to release the 2022 data. And again, it shows you pretty heavily that up to 89% of all cardiologists in the country are in some kind of an employment situation or academia, and only 11% are in independent practice. Private equity is the new kid on the block. If you haven't been watching private equity, pay attention to private equity. We have seen it in our colleagues. We've seen it in emergency rooms. We've seen it in anesthesia, radiology. It is now heavy into cardiology. So far, they have only gone to the independents and have convinced the independents to come into a private equity employment model. There is now a case study that is going on in Florida where they've actually taken the first employed group of cardiologists, put them into a private equity, and they're going to challenge the restrictive covenant and all the things that come with that. The last part is a new part that I just put on this slide. I've done this talk a few times. This new slide is I'm seeing more and more physicians across the country, maybe not here at Mount Sinai, but being invited to become unemployed. That's the polite way of saying we're going to terminate you. Because what the hospitals are finding is that they can no longer afford the cardiologist. That delta between their compensation and perhaps what their contribution margin is widening and widening. So what can we do? What can we do to keep physicians whole, to have them be able to practice at the top of their license? And we're sort of looking at this model in the Midwest specifically is where there's a couple of these going in now, where physicians are leaving employment. The hospitals still want to stay aligned. They just don't want to necessarily pay that high a rate for physician compensation. So I'd keep my eyes on how that evolves for our physicians. Number 4, workforce shortage. This is something that it is nurses, but it's really in my world, it's rad techs, it's echo techs, it's nuclear techs, it's vascular techs. It's those individuals that we desperately need as part of our team that are harder and harder to find. We used to say, does anyone want to work during the Great Resignation? I'm not finding that quite so much anymore. We're just finding an incredible difficulty in finding people to work, and I don't think it's going to get better. We also know about the shortage of cardiologists. So over 1 in 4 cardiologists are over the age of 61. So you look to see how you're going to possibly make up using our RVU model, because that's all we've got. We don't have nearly enough cardiologists to serve the needs of the country. And it's not going to get better. So this is from the American Hospital Association. I saw a study. I'm a nurse by background. I saw a study coming out of nursing school where 80% of the nursing graduates do not want to work at the bedside, because there are so many opportunities for nurses now that working at the bedside is not top choice. What does that mean? Because the acuity of our patients in the hospital just continues to grow. What does that mean if we don't have enough nurses at the bedside? How are we going to do that? How are we going to train other people in the team to take their place? We had a great talk about AI, so I'll kind of skip through AI. I think it is something that we need to learn with. I think we also heard that the human factor is critical through AI. We have AI both in equipment and technology, which can be a huge help, but we also have it as it relates to research and all kinds of other things. So I think learning to live with AI, having it work with us and not by us, is going to be really, really important. The goal for AI implementation to optimize patient care, I happened to have the privilege of being in São Paulo last week. Their ICUs have got robots that visit the patients. There's a central physician that works with the patients, and it was fascinating, A, to see it working, but B, to see the patient satisfaction component. So having AI for pattern recognition, that's what AI is good with, machine learning, but having it for risk assessment also becomes very, very important. And of course, clinical support. How can we use AI to clinically support what it is that we're doing? I happened to ask ChatGPT how to do a physician compensation plan. You'll be very glad to know it came up with a very nice model. I needed to do a few tweaks in it. But I think we do need to be careful what he can and can't do, but it's pretty amazing what he can come out with. One of my healthcare systems I work in too has put a mandate out that none of the physicians can have an email address associated with AI, that they must have a personal email, that they are trying to keep AI away from the bedside at this time and point. So I think we're going to see a whole lot of this evolve as to how we can appropriately use AI in our world. Number 2, care transformation. I don't know, I haven't been up to any of your waiting rooms, but John Rumsfeld sent me this slide, and I thought it was a perfect slide because the waiting room on the right looks exactly like mine. We pushed the chairs back for COVID. It was really nice of us, but the bottom line is we still do our waiting rooms kind of the same way. We used to have check-in from cars during COVID. Patients rarely had to wait. How fast we got away from that. But care transformation is critically important. Need to keep our patients in the center for care transformation. Preventative, we heard a lot from Dr. Fuster today. How early do we start looking at our patients? How soon do we start teaching and training as to what their risk factors are and how low their LDLs need to be? But putting care transformation in the center of this, not just talking about it, but actually doing it becomes really, really important. And I can't leave without talking for a couple of minutes about the social determinants of healthcare. This is one of the things that just amazed me coming out of COVID. I think we do such a great job with our patients. And then when I realized that only 20% of what you all do for your patients really determines their outcome, the reality is 80% of what makes that patient up, their socioeconomics, where they live, what their education is, what their family support is. We give them a diagnosis of heart failure. We give them 7 drugs with differing methodology of how to take them, and they go home and they're completely confused. So how do we use our team-based approach to healthcare to impact those socioeconomic factors? Because we can't change those. It is the critical element of how we're going to redesign and change healthcare by realizing that the physical environment and the socioeconomic factors of our patients more than ever will determine their outcome. You'll often hear it referred to as personalized approach to medicine. We have to meet our patients where they're at. If they happen to be Hispanic and they happen to have a diet in heavy salt and they come back in heart failure every week after they've been to mom's for dinner over the weekend, we need to understand that that's where that's coming from and not just assume that they know what we're talking about. So personalized healthcare, in my opinion, this is the number one thing that's keeping me up late at night. So as is health equity and equitable access to healthcare. So the college has a health equity strategy. I think it's apparent on us to all have a culture of strategy within our organizations for ensuring that we have change management, both equity in our groups and our teams, as well as equity to access for our patients no matter where they are, and to prioritize health equity in every single thing that we do. Eliminating the disparities in healthcare is each and every one of ours responsibility and something that we cannot shirk. It's very important. I put this up here because I found when people say to me, okay, fine, great talk, Kath, what do we do about it? These are 3 things that we have done in our organization to actually start to change the culture. So starting up with leadership and governance to set that tone for health equity and access, from your board all the way down to your leadership teams, making sure the people and the culture that you hire live that mission, that they believe in the same things that you believe, and then actually using data. You're all clinicians, so we know that we use data every single time in order to help us do what we want to do in a good way. So I'll leave you with 2 final thoughts. This I use frequently. If you want to take any of those other 10 items that we talked about and actually implement them. These are the key drivers for organizational change, going from establishing the urgency and why you need to make the change all the way up to instituting the change. It's a stair-step process, and if you take each one and go through the process, you will find that you'll be very successful at the end. Keep an open mind to innovation. Prioritize your workforce flexibility. We have to be flexible, both in physician work styles. We have to have flexible work schedules. You know, no more of this is what a cardiology work schedule is, and you work 80 hours a week, and that's how it is. Dyad leadership, I'm a huge proponent of dyad leadership. Obviously, that's why I'm in the position I'm in the college. I have my physician lead, he has me. Together, I like to think we can do great things. Having those two brains, the clinical brain and the administrative brain, work really well. Make sure you're solving to the problem, and of course, monitoring your trends. And I want to leave, yes, I do want to leave. I do want to leave with probably one of the most exciting things that have come from the college and the House of Cardiology over the last couple weeks, and that is our belief that it's time to have a new CV board. So we are actively in that process right now. I think you all have heard the announcement. There's a big webcast on November 14th. Please join us for some of the details as we get ready to submit our application to ABMS so that cardiology can indeed be a distinct and separate board. And I think it's something that you all deserve and something that will be really, really extremely exciting. Thank you.